Okay, so we are officially back and ready to go. I think the morning was just spectacular, some great presentations. This afternoon we have another two terrific presentations. Our first speaker in the afternoon is Dr. Mohamed, and he is working out of Cleveland, not the Cleveland Clinic though. And he's here to talk to us today about the clinical trials and the future of treatment. So please welcome Dr. Mohamed.
Thank you. What is here? Oh, here? Okay. There you go. Good afternoon, everyone. So it's definitely a pleasure to be invited with NCAN, and I hope you guys enjoy your time. So my name is Mohamed. I am the director of the Neuroendocrine Tumor Program at Case Comprehensive Cancer Center, Seidman Cancer. Today, I would like to talk to you guys about what is the future for neuroendocrine tumors, what we have as a standard of care, and what every patient of you will expect according to what is your primary tumor and what type of options you will have for your therapy. So these are just my disclosures. So what is the current treatment options? Mainly, I'm talking here about the metastatic gastroenteropancreatic neuroendocrine tumors. Even if you have a stage 4, as our colleague just mentioned, and Dr. Ho, you still have a surgery as an option. Definitely not everyone will be, appropriate for surgery. We need to know what is your primary tumor, what is your grade, what is your differentiation, how many of the tumor bulk do you have? Do you have mainly basically hepatic metastasis, or also you have an extrahepatic outside the liver lesions as well? All these factors need to be discussed in a multidisciplinary fashion so you can know if you are appropriate for surgery or not, in addition to your age and your other comorbidities. Sometimes we're starting with chemotherapy, and then we go with surgical debulking. That's especially in the patient with pancreatic neuroendocrine tumors. So if you are a patient with metastatic pancreatic neuroendocrine tumors, you do not have a lot of liver tumor burden. We know that surgery can be an option, but we just need some shrinkage for your cancer. We definitely use with capecitabine and temozolomide as one of the options for these patients. In the small bowel neuroendocrine tumor, unfortunately, the results are suboptimal. So if you are a patient with a small bowel neuroendocrine tumor metastatic, and the surgeon, you know what he say, I can do a cytoreduction, but can you just start something for me to decrease the lesion size? We do not have the same results that we have for pancreatic neuroendocrine tumor. Pancreatic neuroendocrine tumor can reach up to 50 or 60% response. And the patient can still have this benefit of chemotherapy for up to 2 years after they finish their chemotherapy. The results are not the same for the small bowel neuroendocrine tumors. So you can see that the primary tumor really impact our decision for chemotherapy and surgery. Liver embolization, whether radio or chemoembolization or planned embolization, again, that's depend on where is your tumor at, how many of lesions you have in your liver. Is that something we can do safely or not? Are you a patient who have somatostatin receptors that you are going to be eligible for PRRT in the future? So I need to keep that in mind to avoid the extra liver toxicity if I'm going to do radioembolization. So this is also need a multidisciplinary discussion with nuclear medicine and the intervention radiology during our tumor board. Systemic treatment, this will be the main of my talk. What options of systemic treatment, something you will take oral or IV, that is going to affect all the neuroendocrine tumors in your body. And there are 4 concepts we are talking about. Do you have receptors above your cells or not if you have well-differentiated neuroendocrine tumors? If you have receptors, there are specific types of medication you will be eligible for, like somatostatin analog and peptide radionuclide therapy. If you don't have receptors, do you think that target therapy will be beneficial for you? And the main FDA-approved one is the Afinitor, everolimus, and the Sutent. Not every patient will be eligible for both of them. For example, if you have a pancreatic neuroendocrine tumor, Sutent will work for you. But if you have a small bowel neuroendocrine tumor, we do not have the same data for using Sutent in this subgroup of patients. So even using the targeted therapy, where is your primary tumor will definitely impact our decision. And the last, as I told you, is the cytotoxic chemotherapy, whether you use it as a neoadjuvant, preoperative, or you can use it in the patient who have metastatic neuroendocrine tumor, well differentiated, mainly in the pancreas, and surgery may be not an option especially in these patients who are having a lot of disease or have symptoms like pain, and you want to really reduce or shrink the cancers. Cytotoxic chemotherapy will be an option. So this is the four main concept of how we treat the gastroenteropancreatic neuroendocrine tumor. When we see any patient, we think about these four concepts. Do you have the somatostatin receptor or not? So you need to have the gallium-68 or copper-64 from the beginning if you are metastatic, well differentiated. Are you going to be eligible for somatostatin or PRRT? I have these questions a lot from my patients. They come to me and they say, I do not have receptors. Is somatostatin analog will be beneficial for me or not? And the answer, we don't know really, but I think most of the data that the patient got benefit from the injection, they do have the receptors. But we don't have a study showing that the patient who do not have the receptors will benefit or not. Theoretically, most probably will not have the same benefit. And it's the same if they are progressing. We are going to do PRRT, also depend if all the lesions have a good isotense somatostatin expression. So before I am going to consider PRRT for your treatment, I'm going to sit on the tumor board. The nuclear medicine physician need to go through every single tumors that you have and show a specific score of uptake in the scans that you have. If you don't have that and maybe you have some intense in some lesions, and other lesion does not have any uptake, treatment will not be as effective. The same for targeted therapy. We target specific mutation, like the mTOR inhibitor. I'm going to go through that in a minute. Or we target the blood vessel, which innervates the neuroendocrine tumors. Neuroendocrine tumors are very hypervascular tumors. They need blood supply for growing and metastasis. So one of the concepts that if you target or you have the anti-angiogenesis, you can basically block the growing of this tumor and keep it stable for a long time, and also sometimes you even may shrink it. The problem that with the targeted therapy and anti-angiogenesis, the response rate is less than 9%. So it's not a great treatment to start, for example, before surgery. And you need to tell your patient that, because you're going to expect once you start the treatment, after 3 or 4 months you do the imaging, and everything looks smaller. That's not the case. If you keep it stable, the treatment is working. And the last one is the chemotherapy. So you can see in the last decade, significant advancement and increase in the options of treatment that we have. Starting first with only the short-acting octreotide, and then after that you have the sandostatin, after that lenalidomide. You have the everolimus that they did 3 trials for them, Radiant 2, Radiant 3, and Radiant 4. And I'm going to tell you in a second why they did 3 trials for 1 medication. You also have Sutent. You have the telotristat Zermello for patients who still have uncontrolled carcinoid features, and they are taking the sandostatin or lenalidomide. And then you have the chemotherapy, the CAPTEM. We started with retrospective trial with Dr. Strasberg, and now we have a phase 2 trial also documented that this patient got benefit from CAPTEM chemotherapy, mainly in the patient with pancreatic neuroendocrine tumors. Okay, so let's talk about somatostatin receptors. To make it easy for the patient to understand, if you have the receptors, if you have the lock, we have the key. We have the key to diagnose you, we have the key to treat you. Diagnosis will be through the PET scan copper-64 or gallium-68, and locking the tumor from growing will be through the somatostatin analog. So when I'm going to start my patient on somatostatin analogs, you want to first understand what does that mean? What's somatostatin analog? Somatostatin is a hormone that your body is secreting for multiple areas, and basically it's decreased every other hormone. So it's decreased the gastrin, it decreased the serotonin. So basically if you have a lot of serotonin production, gastrin, VIP, it makes sense that the somatostatin analog, something looking like the somatostatin, is going hopefully to help with the hormonal secretion. So why we don't just use the somatostatin? It's something natural, because the half-life is only 1 to 2 minutes. And that doesn't make any sense. I cannot just keep giving my patient treatment every 2 minutes. So I need something long-acting. That's why we say somatostatin analog. So there are 2 phase 3 trials. Has been shown if you have the receptor, the somatostatin analog, whether octreotide or lenalidomide, is going to help with blocking your cell from producing the hormone, but it also is going to blocking the cell from growing, what we name as improved progression-free survival. PROMET trial was mainly for patients taking octreotide intramuscular every 28 days, and the CLARINET was mainly for using lenalidomide. the difference between them, again, has not been established. We cannot say that one is better than the other. The trial is different. The ClearNet trial showed that lenalidomide is working for patients who have low or high liver tumor burden. Not the same assessment has been happened for the PROMET trial. It does mean if you have any patient with high liver tumor burden, you should go immediately for lenalidomide. No, I'm not saying that, but the trial did have this piece of information. So see some differences between the two trials, but the two medications at the end are the same. I can tell my patient if you are a little bit overweight, giving an intramuscular drug will not be very feasible, and the bioavailability, how much your body will absorb from this drug, will also be questionable using the intramuscular. Maybe at these cases I need to use the subcutaneous lenalidomide. So who are the patients who are going to benefit from octreotide or lenalidomide? You have a metastatic, well-differentiated gastroenteropancreatic neuroendocrine tumors. We use it as a backbone, the first-line therapy in this patient. And some of these patients, especially with a grade 1 and grade 2, can have a stable disease for a long time. So what's new? As Aman just mentioned in the morning, we have an injection and we keep asking for a long time. What's more convenient? I think convenient to have either an oral something or a patch. And this is basically what the beltusitine came in the plan, that now we have a clinical trial using this oral somatostatin analog for the patients who having, again, somatostatin receptor. So you need to have the SSTR or the somatostatin receptor imaging as a baseline. But the difference here, this medication is going to control your carcinoid feature, control the hormone secretion. That's going to have the same benefit from controlling your tumor from growing. As I mentioned, it is the lock. It's going to block your cell from growing and producing hormone. The answer, we don't know. So it is going first to control the carcinoid feature, and if it is positive trial, it makes sense with the company will go also after that for a phase 3 trial to see if there is a progression-free survival benefit or not. But this is definitely one of the advances. So if you are a patient taking octreotide or lenalidomide for a long time, mainly for hormonal secretion, ask your institution if they have this trial or not. So this will be a phase 2 trial. Again, they have 30 patients. They are going to compare between 2 doses of this oral somatostatin analog, one of them 40 milligram and one of them 80. We'll see which one will have the better tolerability, which one will control the hormonal secretion. So that's definitely one of the excited clinical trials. Again, if they have the lock, we have even more options for you using what we call the peptide radionuclide therapy. And just very simple for our patients, we're using a very similar material to the somatostatin analog, and we attach with it a radionuclide material, which is going to go to every neuroendocrine tumor in your body, which have the somatostatin receptor, by a specific intensity that we just discussed. It needs to have a good, what we call kerning score, and have a good, all of them, not only 1 or 2 lesions, attached to it and deliver a very concentrated radiation. This treatment has been in Europe for many, many years. But we did the first phase 3 trial here. And the phase 3 trial showing almost 80% decrease the risk of disease progression and death. Most of the patients are stable in this disease for about 2 years, but every patient is different. So if you have a grade 1, you may not have the same results for someone have a grade 2, and definitely not the same if someone have well-differentiated grade 3. So the patient grade can affect the outcome. The amount of disease that you have can also affect the outcome. For example, if you have a lot of mesenteric lymph nodes, we know that this treatment, before it will shrink the tumor, can cause a lot of inflammation. And this patient can have bowel obstruction. The percentage is still not clear, about 20 to 30% at max that we hear. But this patient does not seem to benefit the same from someone who does not have a lot of mesenteric lesions. The same for bone lesions as well. It doesn't seem to work very well for most of our patients who have a lot of bone lesions. So your grade, your differentiation, what type of tumors you have, all that will affect the outcome. So now we have, the study was done mainly in patients with grade 1 mid-gut. This is the NETTER-1 trial. Now we have a study, what we call the NETTER-2 study, will examine 2 questions. Is it going to have the same benefit for grade 2 and grade 3 or not? But also we are going to treat the patient who are naive as a first line. So we don't need to wait until they progress on somatostatin analog. So this is definitely one of very exciting trials that we are looking, hopefully, to have the results. They are going to have 222 patients, and they are going to randomize them to either the Lutathera plus the octreotide here mainly for symptoms control, versus a high dose of octreotide. And the primary endpoint for this patient will be progression-free survival, and they have many secondary endpoints, including response to adverse events and disease control rate. So this is definitely going to change our treatment landscape. If the trial came back positive, number one, you can use it as a first line. Number two, you can consider it definitely for patients with a grade 2 and grade 3, which we do right now sometimes if the patient have good somatostatin receptor expression. But that will be an evidence-based. So this is definitely one of the trials that's going to change our treatment. The edotriotide, it's one of the novel, again, looking like somatostatin analog attached with the lutetium-177. What is the difference between this trial and the NETTER-2 trial? Again, this trial still for grade 2 and grade 3 GEBNET, and this is a novel radio-labeled somatostatin analog. It's a prospective randomized trial. The patient will have unresectable or metastatic grade 2 or grade 3 neuroendocrine tumor of gastroenteropancreatic tract, so small bowel, pancreatic. They are going to use it as a first line or later again. But the good thing about it, that's also giving us information about sequencing of treatment. Who said that doing the PRRT is better than doing the CAPTEM or everolimus in the second line? No one knows. We don't have a good sequencing treatment trials for this patient. So this is one of the trials. The additional information will give us that what should be the appropriate sequencing of your treatment that you are going to choose for your patient, even if they have good somatostatin receptors. So they are going to compare it with either the CAPTEM, everolimus, or FOLFOX prescribed by the primary oncologist. I can tell you, I don't think a lot of us is using FOLFOX. We use it sometimes in the small bowel neuroendocrine tumor if they run out of options. So COMPETE trial, another trial to give us more information about sequencing. So this will be the patient with well-differentiated GEBNET who progressed at least on the first line therapy, maybe somatostatin analog. You're going to have more than 300 patients, either randomized to the Lutathera. So the treatment itself is not new. Like this couple of trials I'm showing you, trials will give you more information about which therapy you should use before which therapy, which is an information we do not have any evidence about yet. Or they are going to take the everolimus, the 10 milligram. Again, progression-free survival is the main endpoint. They want to see how long it will take your cancer to progress. We're either taking this or this. And this will give us also another piece of information about sequencing for Lutathera versus everolimus. I think this is also one of the trials which will impact our way that we treat our patients. So how about the new radionuclide therapy? We all heard about alpha-targeted therapy. You know, the alpha therapy compared to the beta, it have high energy level and short path length, so hopefully it will have high efficacy. I can give a comment about the toxicity. From the phase 1 that has been published, I think in NANETS 2021, the first time, the abstract, it doesn't look like it is toxic, but you cannot compare the alpha-targeted therapy with lutetium-177. It's very early. You cannot compare oranges with apples. This is the lutetium-177 got the FDA approval, have a phase 3 trial in almost more than 400 patients. But the alpha-targeted therapy, most of the trials are either phase 1 trial or single institution experience. They are very promising, and the results and the concept is very promising, that you are going to have more higher energy radionuclides that hopefully will have even more response, will be more effective, and the hope that it will be as toxic or maybe less compared to the lutetium-177. So they did the phase 1 trial. Before I go to the phase 1 trials, there are many alpha-targeted therapy that you can use. You know, there's the actinium, there is the lead, this is the one that they use for the phase 1 trial, and the thorium. Again, there is no any study to compare either one of them. This is all still early in the clinical development. So the phase 1 trial have 20 patients who never had PRRT. So this patient progressed on somatostatin analog, are naive patient, never got treated with PRRT before. And they have 3 cycles of the alpha-targeted therapy, at least 3 cycles, I'm sorry. 6 patients had the whole 4 cycles. The response rate was quite impressive, almost 83%. Again, that's only 20 patients. So you cannot compare and say the response of alpha-targeted therapy is definitely better than PRRT. You can say it's promising, but still we have a long way to go. And it does not have a lot of side effects. Definitely, it seems I have a couple of my patients on the trials. They have slightly more hair loss when I compare them with the PRRT. They also have some back pain, dyspnea, kidney toxicity. I will not believe it until I see a phase 2 trial. And the reason for that, it's quite rare for PRRT because we give the patient a lot of amino acid to protect the kidney. So I think it's the same will be alpha-targeted therapy. So I want to wait until phase 2 or phase 3 to see if we have the same kidney toxicity or not. So now we have a phase 2 trial is going on with using the same alpha-targeted therapy. So you have more patients, 34 patients. Again, all these patients progressed on somatostatin analog. None of them got the PRRT. And they are going to go through the 4 cycles of alpha-targeted therapy with a primary endpoint, response rate, and safety. With response rate makes sense for a small phase 2 trial. So again, it's a phase 2 open-label study. Patient was unresectable or metastatic neuroendocrine tumor. So if you have neuroendocrine tumor of the small bowel or the pancreas, you progressed on somatostatin analog before rushing into PRRT if you want to discuss with your physician that he thinks that this will be a appropriate trial for you or not, I think it's worth it. Again, you should not receive any PRRTs. Once you receive the lutetium-177 PRRT, you are not eligible for this kind of trial. If you received liver-directed therapy, the radionuclide one was the 4 months, like 4 months before you had the liver-targeted therapy, or you have the non-radioactive within 6 months, you still can be eligible for the trial, which was not very clear in the phase 1. But for the phase 2, even if you received a Y90 or liver-directed therapy, you may be still eligible for the study. So I think it's worth it to discuss with the team who running the study and see if you are qualified or not. So this is one of the new agents that we expecting to see the results of the phase 2 trial. And that's not the only place. There's other places I know that they are now going through an alpha-targeted therapy trials as well. So we're still also waiting for that. What is the update for the targeted therapy and the angiogenesis? So mTOR is a protein that's really important for cell growth, proliferation, and survival. So when you have an overactive mTOR, you have basically more cell proliferation and growing. So by sense, if I can inhibit the mTOR, I can control your tumor growing. They did 3 studies, Radiant 2, 3, and 4. The reason why they did 3 studies, because every study have a specific primary tumor. Radiant 2 has the patient which have carcinoid syndrome. I didn't touch base on that from the beginning. Is carcinoid an accurate terminology for neuroendocrine tumor? Absolutely not, and hopefully one day we'll change it. Carcinoid was discovered in 1907 by a German pathologist who gets these cells out of the small intestine. He did not think it's looking like cancer, but also does not look like normal cells. So he names them carcinoid, cancer-like cells. Can I say these are cancer-like cells? Definitely not. They are cancers. They are indolent cancers. They are slow-growing cancer, but they are fact malignant cancer. We cannot say they are benign. So the terminology is not very accurate. Why we still use it? Because if someone have a neuroendocrine tumor in the lung or the small bowel, they share the same carcinoid features. They increase the serotonin production and other hormones. They have the same clinical syndrome. So when I say the patient have carcinoid, I mean that the patient have a small intestine or lung neuroendocrine tumor, which is functional and secreting hormone. So this was the Radiant 2 study. And the results was almost negative. So if you have a patient with metastatic small bowel neuroendocrine tumor, they are functional, they are producing hormone, everolimus should be the least in your options. It's not the great option. Radiant 3 was mainly for pancreatic neuroendocrine tumor, and this definitely was positive study for improving progression-free survival. The same was for Radiant 4, for the patient who have non-functional neuroendocrine tumor of the lung, of the colorectal, and other gastric nets as well. And this also was positive study. So who is the patient are going to be qualified for everolimus? If you have a metastatic gastroenteropancreatic tumor, non-functional small bowel, this is the patient definitely I'm considering them for everolimus. Whether you have pancreatic, whether you have a small bowel which is non-functional, whether you have lung. If you have a functional small bowel neuroendocrine tumor, this is the least effective treatment and should be the least in your options of treatment. We still give it, unfortunately, because we don't have other option for a small bowel, but it should be the least, definitely. Again, neuroendocrine tumors are very hypervascular tumors. They need blood vessel to innervate them, metastasize, and grow. So the study has been done in patients with metastatic pancreatic neuroendocrine tumor. This was mainly a phase 3 study, and it did show improvement in progression-free survival. Who is the patient would be qualified for SUTENT? Again, patient with metastatic pancreatic well-differentiated neuroendocrine tumor. If you are a small bowel, SUTENT is not a good option for you because we do not have the same data in small bowel neuroendocrine tumors. So what is new in targeted therapy? Cabozantinib is definitely one of the new medications, and this is has been documented in early phase trials that it does improve the progression-free survival. So the patient who have well or moderate differentiated, well we mean here grade 1, moderate is grade 2. So if you have a grade 1 or grade 2, moderate differentiated pancreatic or extra pancreatic neuroendocrine tumor, which is very exciting because if this study came back positive, we have another evidence base for targeted therapy in the small bowel that we are lacking for the everolimus part. Again, you need to have a disease progression. Initially, they put that you need to have an everolimus, somatostatin analog and everolimus, or either one of them, but it need to have an everolimus as one of your treatments that you already progressed on. Recently, they removed this condition. So only one treatment other than somatostatin analog, you will be qualified for this trial. It's an oral medication, 60 milligram a day, comparing with placebo with a primary endpoint progression-free survival. How it works, again, it's considered a tyrosine kinase inhibitor, affecting, in addition to the blood innervation for neuroendocrine tumors, many other genes as well. And this is one of the trials that definitely we are waiting for because that's very strong evidence based of a new targeted therapy in patients with pancreatic and extra pancreatic, including small bowel neuroendocrine tumors. So if you are a patient with either pancreatic or small bowel, progressed on somatostatin analog, maybe PRRT after that, it doesn't need to be everolimus. If you take everolimus, that's fine as well. Please ask your institution if they have the cabinet trial. Sorafenib, one of the other tyrosine kinase inhibitor, which is inhibit, again, a lot of what we call the VEGF and FGFR, and also inhibit what we call the tumor immune invasion. This medication has been shown it works for patients with pancreatic and extra pancreatic neuroendocrine tumor. Unfortunately, we was not very excited after we got the FDA disapproval for this medication because we were all waiting for another new targeted therapy that we can use for our patients. But the FDA would like the study also to be done for American patients because both of the phase 3 study was done outside the US, mainly in China. So we cannot say it's one of the standard of care. I have no idea how hard to get it off label if the patient start progressing, but definitely it's not FDA approved yet for neuroendocrine tumors. And there are some study going on now as a phase 2 study and more for patients with pancreatic and extra pancreatic neuroendocrine tumor who progressed at least on 2 lines of therapy. And we're definitely still waiting for the results. So sorafenib, one of the things that you keep in your list, but still we have some time before we can go ahead and say it's one of our new targeted therapy. There was a study has been done in some of the institutions, including Case Western, using this sorafenib plus immunotherapy, tislelizumab. This was before the FDA disapproval of sorafenib. And the study basically for patients with well and moderate differentiated neuroendocrine tumors, the GEP-NET and the thoracic neuroendocrine tumors, and other solid tumors as well. So the trial was kind of like a basket trial, having gastric cancer, having colorectal cancer, small cell lung cancer, and the neuroendocrine tumors as well. We have 135 patients who took the oral sorafenib in addition to the immunotherapy. And the trial from the neuroendocrine tumor standpoint is closed because we finished the recruitment of the patients already across the centers in the US. And the primary endpoint is overall survival, safety, and secondary endpoint is mainly progression-free survival and overall survival. This is a trial that we are waiting for the results, but I don't know how much the FDA disapproval of sorafenib will affect or impact the result of this study. One of the very novel medication, which is a drug conjugate consisting of a peptide ligand, basically, that again targets the somatostatin receptor 2, in addition to the DM1, which is a cytotoxic component, will kill the cell, has been also published in the last minutes, presented as an abstract. was basically a phase 2 trial in patients with moderate differentiated mid-gut neuroendocrine tumor. So we here are talking about small bowel neuroendocrine tumor who does not have a lot of options. They having a positive somatostatin receptors because you need something to attach to the receptors, and then the cytotoxic material bind to it will kill the cell. So if you don't have the receptors, again, you are not qualified for such a treatment. The patient at least progressed on one line of therapy, PRRT naive and recurrent. The trial had 32 patients, and it did show, for this trial, it did show that this patient definitely benefit with improved progression-free survival. So you can see in the next slide that this patient definitely have some kind of response and improvement on the median progression-free survival, which is about 9 months. If you compare it with everolimus and Sutent, which is about 11 months, like a year. So it's very close, to be honest with you. And I'm talking Sutent for pancreatic, but everolimus for the other small bowel. So this is one of the new treatments that a randomized trial now is under development, and it will be mainly for the mid-gut neuroendocrine tumor. So you can see more and more options for the mid-gut. Cabozantinib is one of them. The PEN 221 is one of them. Again, ask your oncologist if this is going to open at your institution, because if you start progressing on somatostatin analog and maybe everolimus, if you do not have a functional small bowel, this may be an option for you. Beltuzifan, that's one of the new medications that has been recently approved by the FDA for patients or solid tumors who have what we call VHL, the von Hippel-Lindau syndrome, one of the hereditary syndromes that the patient will develop pancreatic neuroendocrine tumors, brain and retinal lesions, kidney cancers, and has been approved for that, specifically for the kidney cancer. This trial has been done and has been also discussed in the last NANETS conference with patients with VHL-associated tumors. They had 12 patients with pancreatic. You need to keep attention on that every trial now, we do it for a specific disease primary, not just for all neuroendocrine tumor. So either the mid-gut, the pancreatic, the reason for that, they are different type of diseases. Not all neuroendocrine tumor are the same. Biological response to treatment outcome is completely different for someone have small bowel neuroendocrine tumor versus the pancreatic. So the study again had 12 patients, and the patients who have the VHL being tested and was positive, they took the oral medication and almost response 83%. That's overall response, but that's a quite significant and high. So now it's a phase 2 study is going in the patient with pancreatic neuroendocrine tumor, FEO and PARA, and we definitely, I think this is one of the very interesting clinical study. We're bringing that to Case Western as well, because I think if we can prove that this patient will have this kind of response, the next question, can I use it for neoadjuvant as well? That's quite impressive response rate, even more than the chemotherapy. But again, that's only 12 patients. How about cytotoxic chemotherapy? Before recently, we only have retrospective study showing that capecitabine and temozolomide working very well for pancreatic neuroendocrine tumors. And then recently, we have a phase 2 study comparing the temozolomide with CAPTEM, and it was a positive study showing improvement in progression-free survival and overall survival. Simply, the patient will have a longer time for the tumor to progress, and the overall outcome, and they are going to live longer. So that's basically what was the endpoint of the study. So now we have phase 2 study showing that this cytotoxic chemotherapy definitely working for pancreatic neuroendocrine tumor with also a decent response rate. So you can use it for metastatic session. You can also use it as a neoadjuvant in some of the patients with pancreatic. And again, I want to repeat that it's not the same for small bowel neuroendocrine tumor. There was just a recent study published, retrospective, so not a big or a strong evidence, showing that the most patient of a small bowel who is going to benefit from the CAPTEM are those with the higher grades. So maybe if you have a higher grades or high Ki-67, it makes sense that the cytotoxic chemotherapy may work well for you. What is the cut edge of the Ki-67? It is, again, it's under debate. We don't know exactly. But maybe I can say any patient with Ki-67 between 10 and 15% and more and have a small bowel, and you don't have other options, you may consider the cytotoxic chemotherapy, which is also come with a lot of side effects. You need to keep that in mind. You can see example of response of the chemotherapy. So the one above, everyone is above the patient, and then below is the one after the chemotherapy. You can see it's very extensive type of response. And you can bring these patients for surgery and cytoreduction after that. Does all the patient respond like that? The answer is definitely no. But most of the patients, if they have pancreatic well-differentiated neuroendocrine tumor, especially grade 1 and grade 2, they do have a decent response. And sometimes the response is only stable disease with maybe some partial response. But once you stop the treatment, which the treatment can be up to 9 or 11 months, you shouldn't give the treatment more than that for your patients because the risk of leukemia and bone marrow suppression is significantly increasing. When you stop the treatment after 9 to 11 months, they don't benefit from the treatment up to 22 months. So the treatment does not stop when you stop the chemotherapy. Actually, it's still going. And these couple of publications have evidence about that. So this, again, it's a medication that we highly consider for patients who will be eligible for surgical resection or have metastatic, well-differentiated pancreatic neuroendocrine tumors. How about the adjuvant? We keep talking about the patient with metastatic. How about if the patient only have localized neuroendocrine tumor in the pancreas and we removed it? Does this patient need chemotherapy? We use the same strategy in colorectal cancer, for example. If you have a stage 2 or stage 3 colorectal cancer, we removed the cancer. If you have a specific high-risk feature in stage 2, we do recommend that you take the chemotherapy sometimes because that's will killing the micrometastasis and decrease the recurrence rate and improve the outcome. So this is a study, it's a new study, for using the same type of chemotherapy, capecitabine and temozolomide, in patients with well-differentiated pancreatic neuroendocrine tumor. Does all the patient will be qualified for the study? Absolutely not. You need to be a high-risk patient, which means patient with a lot of symptoms from the beginning, pain, jaundice, pancreatitis, tumor size 2 centimeters or more. Dr. Ho was just discussing that these patients, that definitely he took them to the surgery if they have more than 2 centimeter tumors. If you have Ki-67 from 3 to 55%, like grade 2 or more, and if you have from 20 to 55%, you take extra 6 points. So definitely, if you have the higher grade, you definitely need to be on this study after you remove your pancreas. I don't say definitely that you are going to benefit. It's definitely that you may benefit from this study, and we're still waiting for the results. Again, if you have liver mets, so it's not only localized, if you have up to 5 liver mets and they had ablation, you still be qualified for this trial. So the idea that you're having some lesions in your liver does not exclude you from this trial. They are going to put the patient in only 4 cycles, which you see it's less than the metastatic. Metastatic, we can go up to 9 to 11 cycles. Here is only 4 cycles every 28 days, comparing them with surveillance. And these almost 141 patients. The most common side effects of CAPTEM, again, it can cause neutropenia, myelosuppression, it can cause hand and foot syndrome, it can cause diarrhea. We usually use a specific dose, which is, especially for the capecitabine, less than the colorectal cancer, which make it in sometimes less toxic for most of our patients. But it does come with these side effects. We did not forget about patients with bronchial nets, but we don't have the same excitement, I don't know why, for creating clinical trials for this patient, which is unfortunate, but that's the reality. One of the good trial is basically another sequence trial. So unfortunately, it's not really a new trial using the lutetium-177 versus everolimus. Does the lutetium-177 FDA approved for lung? The answer is no. FDA was mainly for patients with gastroenteropancreatic, not for the lung. But this trial is going to answer 2 questions. Number 1, does lutetium work for lung, which we already used it off-label in most of our patients if they have a good intense somatostatin expression and they have metastatic bronchial carcinoid. The second information, does it better than everolimus or not? Because when you go for the NCCN guidelines, everolimus now is the second FDA-approved line. So if you have a patient with bronchial carcinoid, you did the PET scan in the beginning, have all the receptor, you got very excited about treatment, you do the somatostatin analogs, they progress, I'm sorry, lutetium is not the second line. Everolimus is the currently second line. And the lutetium is the third line. But this may change that. Again, they are going to include patients who are treatment naive, which is, that's an extra plus. And you need to have a good somatostatin expression with primary endpoint, again, progression-free survival. How about poorly differentiated neck, which make everyone upset? On all the Facebook group, you can see that most of the patients are very anxious about this type or group of patients. Because we don't have a lot of treatment options for these patients. This is the most aggressive cancer, more than the small cell lung cancer. So neuroendocrine carcinoma and anaplastic thyroid are the most 2 aggressive cancer you can ever see. The 2-year survival rate for neuroendocrine carcinoma, unfortunately, is less than 11%. So we don't have a lot of options of treatment, and once the patient starts progressing on chemotherapy, we are stuck. We keep using a lot of regimens that we use it from a retrospective data, and we don't have a very good evidence. So the only thing about it is the first line setting, we usually use what we call the platinum etoposide, cisplatin or carboplatin plus etoposide. It's medication that you are going to take 3 days every 3 weeks. And you do that for 4 to 6 cycles, according to how your patient tolerates the chemotherapy. Recently, they did another study. They say, how about we can compare the standard of care with the irinotecan and cisplatin? And the study almost showing they are the same. There is no significant differences. So now you have almost 2 options in the first line. So you have the platinum etoposide, and they have the irinotecan cisplatin. The toxicity is different. So if someone taking irinotecan, we expect they may have a lot of diarrhea, stomach pain. If you're having cisplatin etoposide, you're talking more about the myelosuppression, the neuropathy, but also you can get neuropathy with irinotecan and cisplatin because it does have the cisplatin. But this is a cool study to give us another option as a first line if your patient is not eligible for platinum etoposide as a first line. So how about adding immunotherapy? Neuroendocrine carcinoma usually follow any update or progress on small cell lung cancer. Small cell lung cancer, we have a phase 3 trial showing that if you added immunotherapy to chemotherapy in the first line, you do improve the outcomes, the overall survival. It was not very exciting or something like day and night, but it did show that as an evidence-based. So now we have a SWAG trial, which is having all the patients with a small cell neuroendocrine tumor out the lung, extrapulmonary, because they want to have the same evidence that it does work for the lung and outside the lung. And they are going to randomize the patient to atezolizumab, which is immunotherapy, plus chemotherapy for 4 cycles. If you respond well, you are going to be in maintenance chemotherapy. Another arm, you are going only to be in the immunotherapy and chemotherapy for only 4 cycles, and then observation after that. And the third arm is chemotherapy alone. So this trial is going to answer 2 questions. Number 1, do we think that adding the immunotherapy for our patient will improve the outcome or not? Do we think that after they respond, you should put them in immunotherapy maintenance or not? Or do you think there is no difference and it's the same like giving the patient only chemotherapy? They're really excited about this trial and many of other faculty. We cannot say no, I don't want to be in trouble, but if you think about it, the main second line now we use with some evidence in this patient is immunotherapy, something called ipilimumab and nivolumab as the second line. If the patient, this trial was positive, and it came back positive, and they took immunotherapy as a first line, I'm stuck. I cannot give them immunotherapy as a second line. So in my opinion, it may improve the outcome, but it also deprive us from one of the second line therapies that we currently use in our patients. But if you are a patient and your institution has this trial, I think definitely it's worth it to ask about it and see if you'll be eligible for the trial. Coming back to sorafenib, you see, they're just doing trials right and left. So they use the sorafenib plus another basically immunotherapy in a phase 2 in patients who are progressed neuroendocrine carcinoma out of the lung. And basically they have 21 patients with progressed poorly differentiated neck from the GI and other areas, and it did show good response rate and good progression-free survival. Is that standard of care right now? No, it's not. It's still a phase 2 trial. Sorafenib is not FDA approved yet, but it's a promising trial that you need to keep in mind. Before I go to the summary, these 2 trials here I did not put, but it's something not quite old, but has been almost a year. Any patient who progressed on platinum etoposide, neuroendocrine carcinoma, another trial was saying only high-grade neuroendocrine, did not differentiate, either poorly differentiated or well-differentiated. After they progress on the first chemotherapy, they put them in 2 immunotherapy medication, Epi and Nivo. You do that according to the regimen. One study use it every 6 weeks, the other use it every 3 weeks. I don't think there's a big difference between them. It did show quite improved response rate. One of the trials was showing almost 44%, and also improved progression-free survival. So now we have a lot of phase 1 trial using the immunotherapy as a second line, in addition to some novel therapy that we're also waiting for the results of these trials. So in summary, understand your disease. Ask your physician very carefully from the first time you put your step in a cancer center. Ask what is your pathological report. Do you have the right stain to make sure it's neuroendocrine tumor? Do you have the right differentiation from the beginning? Is it really differentiated or poorly differentiated? What's your grade? Are you grade 1, 2, or 3? If you are grade 3, are you grade 3 well differentiated or grade 3 poorly differentiated? Treatment is quite different, and the outcome is different as well. If you are going to be eligible for PRRT, make sure that your case is discussed as the neuroendocrine tumor board extensively, and the physician show you that all the lesions have a good intense somatostatin expression. If you are going to be eligible for targeted therapy, ask why you're taking this targeted therapy. Is everolimus the right choice for you? Do you are one of the patients who have a functional small bowel neuroendocrine tumor, that the data are the weakest? Or you are a patient who have non-functional small bowel or pancreatic or lung, that you may be eligible for everolimus or not. And with every single step, as you can see, we have one clinical trial now, which is definitely going to change our landscape for how we treat our patients. And I want to thank you guys.